Okay. So good afternoon, everybody. The penultimate session. It's been a long 2 days, but I think it's been a really wonderful 2 days. So it's my great privilege to speak to you during this meeting. You know, monitoring and evaluation people often have a chip on our shoulders because we're in conferences like these, we're relegated to the back rooms because we're number crunchers and we are discussing seemingly esoteric topics like logic models and lollipop graphs. But it's really a testament to the organizers of this particular meeting about how much they value data. And they've really ensured that we have time and space to talk about monitoring and evaluation at this forum. And it's been really gratifying for me over the last couple days to hear all of the speakers who've gone before me talk so eloquently about data and the power of data. So, and they've talked about, you know, the data as it relates to the overall epidemic. They've talked about data around stigma and discrimination, as we just heard even today. They've talked about how the faith community has come to help people affected by HIV and AIDS. So my sincere gratitude already for that. Francesca invited me to speak at this event. She asked me to give this audience a training of sorts, a lesson in the basics of M&E is what she said. Because although we talk a lot about data, often there is a dearth of knowledge about the process, the assumptions, the measurement challenges that come up with collecting data and then presenting it. So I'm happy to oblige on that front, but I thought I would start off this presentation by telling you a little bit about the organization that I work for, which is the Elizabeth Glaser Pediatric AIDS Foundation. And I thought I would do that because we do work around stigma and discrimination, and that will put the M&E training that I'm going to give in more context. So my presentation, I'll first talk about EGPAF's work in reducing stigma and discrimination, and my remarks will build upon what you heard earlier today from our CEO and President, Chip Lyons. He talked about how the foundation works hand in hand with faith leaders and the innovations that we have in HIV diagnosis and treatment. I will talk a little bit about what we've done with regards to stigma and discrimination, particularly amongst adolescents and youth. Then I will embark on a very rapid refresher course on some fundamental concepts in M&E. And lastly, I will conclude by showing you how we can use some of these M&E concepts and protocols to measure faith interventions that tackle stigma and discrimination. So in order for me to really talk about EGPAF, as we call it, EGPAF's work in reducing HIV stigma and discrimination, I think I need to begin with the foundation's origin story and with Elizabeth Glaser herself. So Elizabeth Glaser wore many hats in her life. She was a teacher. She was a wife to a well-known celebrity, Paul Michael Glaser, if any of you are Starsky and Hutch fans. She was an HIV/AIDS activist and advocate. She was the founder of an organization that funds HIV/AIDS work all over the globe. But it was clear that she saw herself primarily, first and foremost, as a mother. In 1981, while giving birth to her daughter Ariel, Elizabeth began to hemorrhage and required a blood transfusion. Unbeknownst to her, she was given 7 pints of blood that had HIV, and she contracted the virus. Elizabeth then unknowingly passed on the virus through breast milk to Ariel, and then to her son, Jake, in utero. As Ariel began to show symptoms of AIDS, Elizabeth took her daughter to various doctors in desperate search for treatment and to understand what was ailing her. Numerous tests were performed, and nothing showed up until 1985, when Ariel was tested for HIV and found to be positive. It was then only that Elizabeth learned that both she and then both of her children were infected with HIV. And this revelation was absolutely brutal for her, given the stigma around HIV at the time, and then the lack of treatments, which actually exacerbated the stigma. So Elizabeth and those close to her at the time have spoken candidly about how friends distanced themselves from her and her family. Fellow parents refused to allow their children to play with Ariel and Jake, or declined to invite them to birthday parties for fear that their children may catch AIDS. For Elizabeth, this was an entirely personal struggle. As a mother on a mission, she was desperate to save her children's lives and to protect them from the virus, but also to protect them from those who would stigmatize them. With the help of two close friends, she established the Pediatric AIDS Foundation to raise money for pediatric HIV/AIDS research. Sadly, Ariel lost her life to AIDS in 1988 at the age of 7. And Elizabeth also succumbed to AIDS in 1994. But the foundation and the work that Elizabeth did remained her legacy, and in 2000, our foundation began our important work to fight HIV/AIDS globally. Today, the foundation, as Chip said, works across 19 countries in sub-Saharan Africa, and at the forefront of this work, of our programmatic work, has been to dismantle stigma and discrimination associated with HIV/AIDS, especially amongst adolescents and youth. This is a demographic to which stigma can be particularly hurtful and damaging. So I'll give you 3 examples of EGPAF's work. Across the majority of country programs, the Elizabeth Glaser Pediatric AIDS Foundation has started Ariel Clubs. Named after Elizabeth's daughter, these clubs provide a safe space for preteens and adolescents living with HIV to openly discuss their fears, their condition, and any discrimination that they have faced from others. And over the course of Ariel Clubs, as they're forging friendships and playing games, children get an education about HIV and understand how to cope with and fight back against stigma. They learn to accept their own status, and then they're able to support and protect others like them. All of this ultimately leads to improved clinical and mental health outcomes and a healthy transition to adulthood. In addition to establishing Ariel Clubs, EGPAF has created a community of African youth advisors, we call that Kaya, who provide adolescent perspectives in EGPAF's programmatic initiatives. They offer us a youth lens, which we feel is tremendously important to our work. Kaya is comprised of a heterogeneous group of youth who are between the ages of 15 and 29 across all of EGPAF's programs. And this group works together to offer input and feedback into our work, and also creates and develops its own resources and tools that speak directly on youth-related matters as it relates to HIV/AIDS, including stigma, shame, and discrimination. I think of particular relevance to today's meeting, EGPAF's Kaya group created and disseminated these cartoons as an innovative way to discuss sensitive topics. They're meant to be shared, read out loud, silently, in groups, acted out, role-played, and discussed using the guides that are on the back of them for each cartoon. And EGPAF's experience has shown that they provide open and honest discussions between those with the virus and those without the virus, particularly around stigma. As well, EGPAF has established youth ambassadors in many of our country programs. You're looking at our ambassador in Uganda. These folks promote HIV awareness and healthy behaviors among their peers. This has become particularly important in the era of COVID-19. As we collectively experienced when COVID-19 hit, there were lockdowns, which many governments went into, transport challenges, events got stalled, and services came to a screeching halt in many contexts. So EGPAF's ambassadors noted that this led to self-isolation amongst youth, and in turn, it increased stigma with false reports that people with HIV had minimal chance of recovery if they contracted COVID-19. EGPAF ambassadors have been speaking out and speaking up against these and other myths so that they can counter ignorance with facts. So it's really against this backdrop of EGPAF's work that I want to talk about how we can measure stigma and discrimination, interventions, and really how we do it through M&E. So before we do that, I know I had promised a refresher course on the fundamentals of M&E, so let's do that. We will start with some definitions of key terms because it's easy to get monitoring and evaluation conflated. These are two sets of activities with two different data streams, and they help us to understand our interventions with slightly different lenses. So let's start with monitoring. We can define monitoring as the continual and ongoing collection of routine data to measure progress towards achieving program objectives. When we're talking about monitoring data, we're talking about data that is collected multiple times over the life cycle of a project. We use monitoring data to track performance over time. And for her HIV service delivery project, you can think about it as measuring what are the services that are being provided, what resources are being spent, and what are the outputs that are coming out of your project. And monitoring and evaluation can help you answer the following question. Is this project meeting its numerical targets? Is this project, the beneficiaries, is it reaching it with the activities that as intended? This is a question that EGPAF is constantly contending with. But in contrast, if we look at evaluation, this is a systematic assessment of the design, implementation, and results of an ongoing or completed project. It doesn't require data collection throughout the project, usually just at the start of the project, at baseline, and at the end line, or sometimes in the middle, you can have a midterm evaluation. Evaluations help decision makers understand how and to what extent a project is actually responsible for a particular measured result, and they often tend to explore issues of attribution. Again, a question that EGPAF contends with constantly. They can use control groups or for comparison groups and often require a well planned out study design. When you put the two together, we can think about monitoring and evaluation in the following ways when they're juxtaposed next to each other. When it comes to the purpose, monitoring tracks inputs, activities, outputs, and overall progress, whereas evaluations are systematic, objective assessment of the merit, the value, and the worth of an ongoing project or a completed project. When it comes to frequency, monitoring is regular and ongoing during the entirety of the project, whereas evaluations are usually one-off or periodic during and after the implementation of a project. When it comes to those who conduct the monitoring and evaluation functions, we can think about them in this way. Activities that are usually associated with monitoring are conducted by members of the project itself, whereas evaluations, although they can be conducted by the members of the project themselves, they can be conducted through external evaluators to avoid issues of conflict of interest or bias. When it comes to data generated by these activities, you can think about it this way. Monitoring informs timely decision-making and short-term corrective action for adaptive program management. Evaluations, on the other hand, yes, they are for program improvement and course corrections, but they often inform future projects as well as contribute to the overall organizational learning or public health learning. Okay, so now we've gotten the definitions down. Let's look at the methods and the protocols that M&E uses. So ideally, M&E should be planned right at the design stage of a project. As soon as you think about the intervention that you want to implement, there should be a simultaneous buzzer going off and automatic thinking about how to measure the intervention and its immediate results as well as its long-term outcomes. But the truth is, it's never too late to think about M&E because it's absolutely vital to a project. Similar to that great philosophical rhetorical question that we've all heard, if a tree falls in the forest and no one is there to hear it, did it make a sound? monitoring and evaluation experts will claim that if an intervention was conducted and no one was there to record it, did it actually happen? And I only say that partially in jest. So once we've made the conscious decision to monitor and evaluate an intervention at the design stage, it's critical that the M&E be aligned to the project's pathway of change. That is, that it's important to lay out the components of the project and the sequence of steps that will be needed to achieve our outcome. And the best way to do this is by developing the all too famous monitoring and evaluation framework. So M&E frameworks help us understand the project's goals, their objectives, and then help us define the relationships that then follow between the key factors of implementation. So they tell us about how the project is ideally supposed to work. There is no perfect M&E framework or one framework template that fits everything, but the most common ones, I'll present to you here a couple. So we can have a results framework, which is essentially a diagram that allows us to see direct causal relationships between incremental results of key activities going all the way up to the objective and the goal of an intervention. The logic model is also another framework, and it diagrams a comprehensive visual description of how and why a potential change is expected to happen. So it presents a very high-level map of the changes that you expect to see in a project. So we're going to dive a little bit deeper into a logic model. It's a little bit more intuitive and easy to understand quickly, so that's the one I'm going to use. So a logic model starts with describing inputs. These are the key resources that we need to undertake our project and our activities. Then you have the activities themselves, which are the things that you're going to do to affect change. So what the processes, the actions that you're going to take as part of your project. Then you've got the outputs, which are the immediate and direct results of performing your activities. So usually these are very tangible deliverables or things that result from conducting your activities right away. And then we've got the outcomes, which are derived from your outputs and maybe are a little bit distal from your activities. And they're what your outputs then result in. And then lastly, we have impacts. Impacts are the ultimate long-term results and consequences achieved of the outcomes. So now we've got our entire logic model squared away, which graphically lays out kind of the pathway of change for our project, and we'll do an example together. We can begin to consider indicators for various elements of our logic model. So indicators are metrics that provide information about performance, show achievements, and determine accountability. Indicators measure whether and by how much a project is changing, and how that change may be directly related to the project's pathway of change. They can be defined at each section of the logic model, so you can have indicators for inputs, for outputs, for outcomes, for impacts. And you need to have some consideration when choosing indicators. There are some boundaries. You need to think about the availability of data, the costs of collecting that data, existing systems to collect and manage the data. We want to make sure we leverage what we already have and don't need to build new pathways every single time we want to monitor something. And to the extent possible, indicators must be SMART. So they must be specific, measurable, attainable, relevant, and time-bound. And each of those has their definitions. So once we've got our indicators now squared away, we've crafted SMART indicators, our next step is to really think through data sources and data collection methods. So how will we gather up that data, and where will we get it from? So data sources are really where the data for the indicators that you've just laid out, the SMART ones, can be derived, and the collection methods lay out the process by which data will be collected, transformed, stored, and retrieved for a later time. Data sources can take multiple forms, including HIV testing registers, interviews with pastors and deacons who are filling out a questionnaire, logbooks located in labs. And data can be derived from primary sources, or they can be derived from secondary sources, meaning that they can be new data collection, or they can be collected from previously published or unpublished data in existence already. Quantitative methods can be used for data collection, and they can be subjected to statistical analysis. Qualitative methods can capture participants' experiences using words, pictures, stories, word trees. And so once we've sorted out our data sources and data collection pipelines by which we will access our data, we can then move on to think about the next pillar of M&E, which is data quality. When it comes to data quality, M&E looks at data via the lenses of 5 distinct dimensions, and they are validity, reliability, precision, integrity, and timeliness, and each of those comes with their own definitions. So data can be also actively checked and cleaned using a variety of methods to ensure that they meet those dimensions. So you can perform concurrence checks on data, looking at whether or not data from 2 different sources that are supposed to be matching actually check out and they're saying the same thing. You can look at logic checks where data are checked to make sure that they actually make sense, such as, the cumulative number of deaths cannot be going downwards, which is an error that we have found many times. Outlier checks, where you can check whether or not the results are seemingly out of sync, whether a particular, whether you're doing extremely well or extremely poor, whether that particular result actually makes sense. You can do duplicate checks, where you can check for duplicate entries of the data, and this is particularly pernicious because it can lead you to alter your conclusions if not found quickly. So I will say there's a whole host of additional components to even the basics of M&E, such as data analysis, data visualization, data dissemination, data interpretation, and data usage, which are all incredibly important, and I won't be able to touch upon that today in this rapid refresher, but for our purposes today, I think we can leave it at this. So now we're all M&E experts. So we want to move on I want to move on to show you how we can apply some of what we've just seen, these M&E principles and methods to faith interventions that address stigma and discrimination. So as I mentioned to you, we have to think about M&E at the design phase, and as soon as we craft our package of interventions, right? So in order to use a very practical example in talking with Francesca, she referred me to Dr. David Barstow, who graciously enough passed me his materials on the recommended practices for religious communities to address HIV-related stigma. So this was a training developed for religious leaders that was discussed heavily in workstream number 2 yesterday, if you were part of that. So what I've done here is I have chosen 5 of those practices and kind of compiled them together as our intervention here. So you can look at these, and these are the 5, this is our package of interventions that we want to implement. So faith leaders and FBOs openly talk about HIV/AIDS, consistently and repeatedly giving messages of compassion and hope rather than judgment and rejection. Second intervention is faith leaders and FBOs provide guidance about methods to prevent HIV transmission to their stakeholders. Faith leaders and FBOs lead honest, open discussions around HIV stigma and discrimination and the ways that religion can both help and hurt in this context. Faith leaders and FBOs encourage interaction and discussion with people living with HIV and marginalized populations. And then last piece of the package is faith leaders and FBOs develop a support program for members living with HIV. So that's our package, our make-believe package of interventions, which is based on some truth. So now that we have this intervention, as I said, the first thing we need to do is think about our logic model, build our M&E framework. So let's think through that with regards to our intervention. So the first thing we will start to think about is our inputs, right? So inputs in this case could be funding, could be faith leaders, their staff, and FBOs, their staff time, equipment that we might need, training manuals, brochures, messages of hopes, internet access, anything as basic as that, event spaces to implement all of these activities. And then the package of interventions that I was just talking about, it's somewhat specific, but we need to get even more specific when we talk about the activities. So let's talk about what this actually means. What do we mean by when we say faith leaders and FBOs talk openly about HIV/AIDS and give messages of hope and compassion? So maybe we mean that they will disseminate sermons and messages of hopes through social media platforms. When we say faith leaders will provide guidance about methods to prevent HIV transmission, maybe we mean that they will craft pamphlets and brochures that detail prevention methods and disseminate those. When we talk about faith leaders and FBOs leading honest, open conversations about stigma and discrimination, maybe we mean that they will organize events in the community to educate and destigmatize HIV. When we say that FBOs and faith leaders will encourage interaction and discussion with people living with HIV, maybe we mean that they will hold discussion groups and between people living with HIV and the community members to discuss HIV stigma. And then lastly, when we talk about faith leaders and FBOs developing some sort of a support program for members living with HIV, maybe we mean that they will deploy a dedicated support team who will help people living with HIV, provide them with emotional but also physical support, such as transportation to ART clinics. So those could be some of the very specific activities that we could lay out in our intervention. And then we look at the next piece, which is the output. So what exactly will this result in next? So with regards to those sermons and messages of hope, maybe 100 sermons and messages were disseminated on 5 platforms. When we talk about the pamphlets, maybe 5,000 brochures were disseminated in detailing male circumcision or ART for pregnant women as methods for prevention. When we talk about educational events, maybe 10 events were hosted in the community and that sort out myths about HIV and facts about HIV. When we talk about discussion groups, maybe it's 20 discussion groups that were held that focus on concerns of injection drug users or sex workers around HIV. When we talk about support teams, maybe it's 12 support teams deployed who help people with HIV get transported to ART clinics and help them with psychosocial support. And then what then do we expect to happen? Once these outputs are achieved, what's the next logical thing that happens? And I've put our outcomes, you can have near-term outcomes, you can have mid-term outcomes, you can have longer-term outcomes. I've tried to push us along to the longer-term outcomes so that we can actually see a difference between outputs and outcomes. So in doing all of this and achieving our outputs, what we expect to see is that there's an increased demand for HIV testing, for example, or maybe there's increased demand for PMTCT because people are learning about prevention methods. Maybe there's a change in the attitudes and behaviors of community members around HIV. Maybe there's a decrease in the percentage of people living with HIV and their encounters with stigma and discrimination. We talked about that in the last session. Maybe there's an increase in the number of HIV-positive people accessing HIV and care and that are linked to ART because more are coming forward and they're feeling more free to, without facing the stigma and the discrimination, to access treatment. And then let's look at the last piece, which is impact. So after we've achieved this outcomes, what is the long-term impact that we want to see? It's increased percentage of HIV-positive individuals retained on ART, increased percentage of HIV-positive people virally suppressed, which is the ultimate goal, decreased HIV transmission, decreased HIV morbidity and mortality. So that's really what we want to see. So now that, and this is just one possible approach to a logic model, and this is quick and dirty. There's a lot more that we could put in here and really think through, but I've done this fairly quickly and sort of in a very simplistic way. So now that we've laid out this logic model, let us think through the indicators at each phase of the logic model. And for the sake of time, we're just going to limit our indicators to 3 elements: outputs, outcomes, and impact. So let's look at outputs. So what are some indicators that we could use, right? Number of sermons, messages, and messages of hope disseminated. Number of social media platforms used. Number of brochures printed and disseminated. Number of brochures around male circumcision that were printed and disseminated. The previous one was about PMTCT services. Number of discussion groups held. So you can see these are more monitoring type questions that these indicators would answer. And then with regards to outcomes, let's see what kind of indicators we would use for those proposed outcomes. We could use percentage of HIV positive individuals accessing PMTCT services, something that EGPAF regularly uses. Percentage of HIV positive individuals newly diagnosed with HIV and initiated on ART. A percentage of community members correctly able to identify HIV myths and facts. Percentage of community members self-reporting changes in attitudes when it comes to people living with HIV. Percentage of HIV positive individuals reporting encountering enacted stigma. And percentage of HIV positive individuals reporting anticipated stigma. That's within the self. And then when it comes to, impact, we can look at some more indicators. So this one is really looking at incidence. We're looking at mortality. So percentage of HIV positive individuals retained on ART for 12 months, those who are on ART and then are virally suppressed, HIV positive individuals with new and recent infection, percentage of deaths attributable to HIV/AIDS causes. So this is just a quick sampling of the types of indicators that we could possibly come up with. And looking at this list, there's a whole host of data sources that we can think about, the data collection methods that we can think about. You can imagine that some of these indicators will be involving primary data collection, such as the ones that are talking about HIV attitudes and feelings. But some of them might be from secondary data sources, the ones that are about viral suppression, that are about retention. We can just go to existing registers and collect those. We can imagine administering surveys on behavior and attitudes. We can also imagine gathering data from lab books and registers. We can imagine quantitative data being collected and subjected to analysis, but also qualitative data gathered to elucidate some of the reasons behind that quantitative data. So in a nutshell, that's how the principles of M&E can be applied to faith interventions to address stigma and discrimination. So with all that rich discussion that I've heard over the last 2 days, I think we have the momentum, and it seems like we have the will to make it happen. Data and M&E will undoubtedly play a key role to making it happen, and I look forward to being your partner to be able to do that. Thanks a lot.
Wow, I think we can do better. Thank you so much, Shoba. I am lacking words. Those are the things we really need to improve the work we are doing on the ground. And just to remind us that all the recordings and the presentations will be on the Interfaith platform, so you can go there and download. And a good news, you want to hear it? Yes. Francesca, as a follow-up, was informing me that we'll have a full-day training on monitoring and evaluation in the next future. So Shoba will help us to have a full-day training on that. So thank you so much, Francesca. I think our next speaker will be online. Tiffany, is she ready?
Greetings, everyone. I'm glad to be back here again. And I just want to, again, my name is Tiffany Aholu, and I'm an HIV testing services technical advisor at in the HIV prevention branch in Faith and also the Faith and Community Liaison for Reaching Men and Children with Testing and Clinical Services. Prior to joining the Division of Global HIV and TB, I actually worked in the HIV Prevention Communication Branch on the domestic side. So I'm really glad to be here today to present on a session on a new hope for HIV communication, the power of social marketing and mass media in stigma reduction. And so in my work in the communication branch, I worked on a team where we did actually look at research and evaluation around social media and social marketing campaigns. So I first want to just thank, our Shabana for setting things up for me. You did a great job in setting the stage for the presentation I'm going to be giving today. So next slide. Oh, okay, 1 second. So today I'll be just providing a high-level overview of our messages of hope and highlight the importance of social marketing and mass media in destigmatizing HIV, as well as how FBOs can use social media platforms to take a pulse of what audience think about messages. Next slide, please. So the roadmap, by the end of this session, I hope that you'll be able to describe the purpose of the messages of hope and how faith and community leaders can promote these messages, explain how communication platforms can be effective in stigma reduction, list the type of metrics used in the evaluation of media campaigns to determine audience reception of messaging, and identify how to keep social media audiences engaged with your messages. Next slide. So since the inception of the Faith and Community Initiative in 2018, the faith communities and faith leaders from 10 sub-Saharan African countries have been involved in discussions on how to end the HIV epidemic and ensure the future health of our children, adolescents, men, and children. And the UNAIDS 2030 goals for ending the epidemic states that 95% of all people living with HIV will know their HIV status, that 95% of people who know their status are treated with ART, and finally, that 95% of people taking HIV treatment will have an undetectable viral load, so viral suppression. And that's been stated throughout this Interfaith Preconference and reiterated by the ambassador, Dr. John, during his remarks. We know that we cannot achieve the UNAIDS goals without the engagement and leadership, as he noted, of religious leaders, of faith-based organizations, and other faith and traditional leaders in the community. We also know that about the power of the messages that our faith leaders put out, whether it's, there's a scripture that says that there's life and death in the power of a tongue. And so we know that there is power in the messages and what we say and what we put out there in messages. And so we'll continue with that and thinking about how we can reduce stigma through our communication channels. So the messages of hope, the FCI messages of hope, they seek to equip the religious and the faith community to leverage their social capital to promote a new hope of HIV through media channels in support of the UNAIDS HIV goals and strategies. The messages of hope are intended to encourage people to get tested, to start and maintain treatment, to reduce stigma in their communities by emphasizing that there are new choices for HIV testing, new treatment that is easier, better, and safer, new timing, recommending early initiation of treatment, and new hope, because you can live a long, healthy, and productive life with HIV and help promote and protect your family and community. Next slide. Now, these are just some examples of assets that we have available on the Faith and Community Initiative website that we ask FBOs to disseminate to their followers. These messages associate positive outcomes with HIV testing, treatment, and people living with HIV. This is in contrast to the stigmatizing attitudes that are sometimes associated with HIV. Now, many FBOs under the FCI initiative, they promote these messages and often through platforms such as YouTube, Facebook, WhatsApp, and radio. So now, why do we want to utilize mass media? Well, we use mass media because it's been proven itself to be an effective method of communication to large groups of people. It can affect the personal and the family conversations that we have with each other, our public dialogue on the subject, and the feelings we have about certain people on topics. And this is especially true when trying to correct people's misconceptions about HIV in terms of how to update them on the latest developments and combat stigma that contributes to people not getting tested, seeking care, or supporting others. Next slide. Now, social media, we know that there's more than 4.2 billion people who use social media, and Facebook is one of the most popular social media platforms. Its most widely consumed medium is radio, and WhatsApp, 100 billion messages are usually communicated daily. So social media has an expansive reach and the ability to create dialogue that can change norms that in turn can affect change. And we've seen this continuously with the multiple social media efforts that ultimately affected change in attitudes and even politics, whether that's negative or whether, right or wrong. We do know the power of how these messages have been able to impact attitudes. Facebook is the social media platform that has the most users, followed by YouTube, WhatsApp, and Instagram. And radio is still also very effective in reaching the most people. In fact, this year, radio's reach in Africa was expanded with the designation of new FM frequencies. WhatsApp is the most popular messaging app in over 100 countries. So you can recognize that persons in this picture. You may recognize the person in this picture. And with more than 146 million followers, he is one of the most recognizable social media stars on the planet. He started with nothing more than him and his phone being consistent and engaging his audience. His name is Kabali Lamam, and he's a social media personality with more than 146 million followers. Next slide, please. So now here are 3 commonly used social media platforms: YouTube, Facebook, and WhatsApp. Each platform has its own analytic capabilities. So for instance, on YouTube, you can check to see how many views you've received or how many people watched your video all the way through. Now, again, just wanting to kind of piggyback on Siobhan's example. So she mentioned in terms of one of the activities could be disseminating messages of hope. And she mentioned about different things that we want to monitor, right, with those output indicators. And so this is where this becomes, this type of analytics becomes very useful in terms of being able to gather that information. So going back to YouTube, you can check to see how many views you received or how many people watched your video all the way through. On Facebook, you can see which of your posts received the most reactions or how many times it was shared. WhatsApp has fewer statistics. It's particularly in terms of those that are publicly available, unless you have the business application. You can see how many messages you sent, but you can download separate applications to get more thorough statistics. Now, generally, these statistics are divided into 3 main types: as audience reach, engagement, and sentiment. Next slide, please. So reach would be how many people see or hear your message. And this is also related to impressions, which is the number of times your message is seen or heard. Impressions are also relevant when it comes to TV, billboards, things of that nature. For example, how many times your radio PSA is heard. So radio is a method that continues to have a large reach in participant FBO countries, which is why it is preferred. This is particularly the case where if there's for individuals who may have low bandwidth and may not be able to get all things on their phones and so forth, but radio is still very much active and especially in the villages, right? So engagement is how many times the audience interacts with your message. engagement is harder to determine for radio, but it's easy for social media platforms. So for example, how many reactions, comments, and shares your Facebook post receives? Those are examples of engagement. And then sentiments. Sentiments would be how your audience feels about your message. Again, a metric type that is easier to see with social media. So what the comments on your YouTube video reveal about how the audience felt about your message. Were they encouraged? Did they have more questions? Did they have negative reactions? And this is also true also for Facebook and other, for Instagram and so forth. This is important. This is where unique hashtags are particularly important to use so that you can track what the audience has to say about your messages outside of your post. As you know, throughout this conference, we've been encouraged to use the hashtag. I believe is and I apologize that I don't know it by heart, but we are encouraged to use the hashtag for the conference so that they can go back and see how people are responding, what kind of comments, how many people are really following along using and posting things using that hashtag. So hashtags are very important. Next slide, please. So hashtags have all your content easily discoverable and allow social media users to find and engage with content related to common themes or interests. So if you use your unique campaign hashtag, you can then search on the platform for times where others have used your hashtag and see what kind of things they're saying. So for example, CDC has an HIV prevention mass media campaign called Let's Stop HIV Together. This is one of the campaigns that I worked on during my time in the HIV prevention communication branch. Now, anytime, and they have a hashtag, a unique hashtag that's hashtag Stop HIV Together. Anytime this hashtag is used, it is referencing this campaign. Now, if other people also use this hashtag, I then can search and see what people are saying when they're talking about the campaign. Now, when sharing the Faith and Community Initiative Messages of Hope material, FBOs are encouraged to use the hashtag FCI Messages of Hope altogether. And in all social media posts. In addition, for those countries, so for example, as you may recall, there were 10 countries that were initially funded. And so, for example, we would want to also consider adding the appropriate country hashtag. So like, for example, hashtag FCI Zambia, hashtag FCI Malawi, etc. And this is the reason why that's particularly helpful is because that helps to reduce some of the noise, right? So if we have 10 countries and those 10 countries are all using the hashtag FCI Messages of Hope, well, that kind of gives us the kind of broader universe, if you will, of the different messages and what people are saying. But if we really want to begin to drill down when sharing your social media, this will allow you to further drill down to see what's being said regarding posts that are particular to that country. Next slide, please. So let's do a quick walkthrough of what you might do to track your messages. So the first step is to decide on your message and your audience. So let's say, for example, you may choose to target men who are Christian and provide a new hope message to encourage regular treatment to those men diagnosed with HIV. Second, the second step is to determine the media channel that you want to use given your audience. Which should you use? So again, this is understanding your audience. Are they more likely to be using YouTube? Are they more likely to use Facebook, etc.? The platform you choose all depends on the audience and their messages. So you may decide that men in your community are often interacting via YouTube, so you develop a PSA or use one of the Messages of Hope videos that has messaging and post on your YouTube. You also want to diversify the platforms so that your audience might see or hear the same message on Facebook. And again, this is really important. They might hear the same message on Facebook, YouTube, or the radio, because again, the more you hear it, the more it becomes more normalized It helps to kind of really helps to set up the normalization of those messages, right? And so this is called cross-posting, and it increases your audience's ability to recall the message, thus an opportunity to normalize and create conversation. Next slide, please. The third step is to understand how your audience reacts to your messages. So when is the best time to post? Which images are most effective with the audience? So for your YouTube, you would go back into your analytics and you would look at information on things such as the reach and impressions. How many times was your PSA seen? Engagement. How many times was your video watched all the way through or clicked on for more information or got a thumbs up? And sentiment. What do comments reveal about how men felt about your PSA? Did they leave comments and were they positive or negative? Next slide, please. Finally, after you determine what to post and when to post, for which of your audiences you want to keep doing, you understand why. Because an important part of what makes social marketing and mass media so effective is that the audience is hearing or seeing the message multiple times. And the more you encounter the message, or the more they encounter the message, the greater the staying power and the likelihood of change in a knowledge or behavior. Again, this repetition of messages helps normalize certain feelings and attitudes about people with HIV testing, treatment, and et cetera, in terms of virus suppression, and thus helps to reduce stigma. Now, to keep that repetition and maintain audience engagement, you can schedule posts using applications such as Buffer and Facebook, Meta Business Manager, and others, because you may say, well, how will I have time to do this? I don't have the bandwidth to do this, or I'm a small organization, and this is where these type of scheduling platforms become particularly helpful. But then, of course, this is also where you want to consider engaging with your young adult, your youth and population, right? They can be very helpful in helping to get the messages out there, helping to even create social media content and so forth. And so this is a wonderful opportunity to both engage your adolescent youth, but also you can use platforms that can help to really help with that. And so this makes it easier for you to post more messages ahead of time. And the ideal behind this is to continue to engage your audience with regular content and potentially even get more people hearing and seeing your message, more people sharing your message. So then it becomes like you might initially make a post, but then you want others to share the post. And so this is where that becomes helpful. So YouTube allows you to choose a future date for your video to be published. And Facebook has a scheduler as well, which allows for Instagram posts to be scheduled too. And there are other scheduling apps that you could use as well. And again, this is a great opportunity to engage and have conversations with your youth and young adult audience to just really kind of see what might work for them as well, and which platforms are they more likely to use. Next slide. So currently there are no PEPFAR-MER, what we refer to as monitoring, evaluation, reporting indicators that partners can report to populate reports for routine monitoring. Instead, they are asked to report on or to monitor their indicators via narratives. And as to be expected, there's often a lot of variation in what some countries and partners gather or report. And therefore, it's imperative for partners, including our FBO partners, to be aware of the tools that are available to help track and monitor this dissemination efforts. Hence the reason for some of the examples that have been shared today. But today I'd like to provide a mobilization example using Uganda as one of the countries to highlight. So here you can see that Uganda's COVID-19 lockdown, it included closure of faith communities for several months. So the Uganda office supported more mass media than anticipated, but the costs were low. And because most faith-based media did not charge for airtime, so they were able to keep their costs low. The Muslim Bureau developed sermons with messages of hope and the Orthodox Bureau used social media platforms to reach their members. Similarly, one of the Ugandan partners used traditional mass media as a way to mobilize and promote COVID-19 messages of hope. So here you can see where the partner, one of their partners, and I believe actually that was one of the partners whose video we had a chance to see earlier, the United Catholic Medical Board. So they had 7 talk shows. They used 420 radio jingles. They had 308 DJ mentions. They had 570 spot messages. I believe that's on television. Another partner, they had 256 Sunday services. Another partner had 200 sermon guides. And then you also had WhatsApp. So they had over 48,000 WhatsApp messages received and church, and they also used the church Facebook and Twitter posts. Okay, so I just want to say some takeaways here. I'm sorry, if you could. Okay, so the takeaways. So currently the takeaways here is that using social marketing and mass media is one way that has been shown to be effective in changing behaviors and attitudes. And by being consistent and utilizing positive and relevant messaging, faith-based organizations have an opportunity to destigmatize destigmatize the conversation about HIV and develop support in faith communities for testing, treatment, and resources for people with HIV. And these are just some resources. These assets, again, are available on the Faith and Community Initiative website here. And this is just another resource of 10 key data from Facebook Insights that you might be interested in. And so at this time, I yield the floor to the next presenter. Over. Thank you.
Thank you all very much. I am more than happy in the interest of time to yield my time and for us to move forward. Francesca's telling me no. I can tell you, as someone trained in theological studies and who works very much on the conceptual side, M&E is not my strength, and it is only my deep affection for Francesca Marico that I am standing in front of you in a session entitled with a topic area of monitoring and evaluation, because it is not my strength. So what I told her I would do is to describe some of the challenges I feel and face as part of the academic consortium of the Faith Initiative in terms of the disconnect between what we work with as an academic consortium in conducting some of our work in relation to a broader kind of monitoring and evaluation framework. And I want to use a case study example of what we tried to carry out and some of the challenges we faced, as well as a way forward. We were asked 2 years ago to develop a curriculum for implementation in faith-based health facilities, a training curriculum in faith-based health facilities in one of our priority countries, in collaboration with 2 of our implementing partners in the UNAIDS PEPFAR Faith Initiative, to train the clinical staff and the front-facing non-clinical staff, the staff that work with people accessing services in those facilities, on a stigma and discrimination curriculum to address stigmatizing practices and attitudes and perspectives in the clinical setting. We worked to develop and design a training for implementation in both Christian health facilities and Muslim health facilities in the partner country, and we did that in coordination with 2 national level organizations that were part of the implementing partners of the broader global initiative, and with country officers for both UNAIDS and PEPFAR at the table. That process brought in representatives from the country coordinating mechanism for HIV programs and services within that same country. And there was the idea, well, this is a really important kind of initiative. Let's develop a curriculum that could also be implemented in non-faith-based healthcare settings. Well, that led to a complexity about what needs to be different for anti-stigma curriculum in a non-faith-based setting versus in a faith-based setting, as well as the complications of a curriculum in a Christian health facility versus a curriculum in a Muslim health facility. So as Part of this process, the Academic Consortium and the Faith Initiative conducted a desk review or a literature review of existing resources related to stigma and discrimination and training platforms. We looked at 14 different resources, and some of these resources are across these different kinds of domains that are listed here. 4 of them included conceptual frameworks about what it is we're actually talking about when we use the word stigma and discrimination. What generates stigma? How does stigma play out? What are the drivers of stigma? What are effective models for addressing stigma? Why does stigma come up in the first place? Those are theoretical, cultural, and in the instance of faith kinds of conceptions of stigma, theological frameworks in regard to a stigma. Now, these were largely conceptual, so there was no kind of evaluation component to them, no effort in them to connect the conceptualization of stigma to program design or implementation and activities on the ground. We then looked at various curricula. One curriculum was to be implemented in a community-based organization and in various non-governmental organizations. It was a specific approach for organizations in that context to implement anti-stigma initiatives or elements into their existing broader programs. And that curriculum had an outcome evaluation, which is quite common for training curriculum. And I also admit that having heard from my colleague and friend from EGPATH, I may be using the word evaluation and monitoring incorrectly because this is not my area. I've always called this outcome evaluation, but you may come up to me later and say it's outcome monitoring. But it's designed to assess how participants in a training indicated from a self-evaluation how their knowledge or their intention to do something changed by virtue of participating in the training. We looked at 5 curricula for clinical settings, specific approaches for how to implement stigma and discrimination in clinical and health systems into aspects of clinical care and into patient or consumer service delivery for non-clinical providers that are front-facing in clinical settings. All of them also had outcome evaluations. What did the training do in regard to a change in knowledge, intention, attitude in relation to stigma and implementation? And then we looked at 4 curricula for implementation in congregational settings, working with religious leaders, with local faith communities, to implement some form of anti-stigma elements into, it says clinical care there, into congregational care, into congregational ministries and programs. They also had an outcome evaluation. And then finally, we looked at 4 larger community implementation toolkits in regard to anti-stigma efforts and programs. These were designed to be implemented across a variety of settings in local communities, clinical settings, community-based settings, local congregations, churches, temples, masjids, community-based organizations, all kinds of different programs. And they articulated general principles and strategies for a local organization to develop their site-specific kind of anti-stigma programs or initiatives. And these curricula, these toolkits also had an outcome evaluation about how much did the participant who went through this training to learn about this toolkit learn. As we talked with the team on the ground in our priority country where we're working to implement this anti-stigma curriculum, we realized there was a tremendous disconnect between what they were telling us they wanted the curriculum to do, which was a large-scale, macro-level outcome evaluation or impact evaluation kind of measure. We want this curriculum to lead to 0 experiences of stigma in clinical settings. A completely unrealistic but laudable goal in terms of scale and impact for what we were going to be able to achieve with a single curriculum in a time frame of 6 to 8 months for implementation. And so we tried to think about, well, how do we get between this kind of visualization of large-scale kinds of impact and what we can actually do on the ground. In my experience with lots of programs from the faith sector working in the field of HIV, lots of friends and colleagues in this room and in other parts of the world, this is a key question, and it's a key kind of disconnect, is We think often out of our faith communities in terms of vision, in terms of stories and commitments for creating a new way of human beings relating to one another, based in compassion and care and love. Monitoring and evaluation folk think about measuring specific, measurable, smart indicators around elements of a program. And that disconnect between our visional aspirations and the reality of implementing a program on the ground, in my experience, often lead faith-based organizations to overpromise in terms of what they can deliver and produce when they talk to program staff and funders and policymakers. It's not like we're trying to be too optimistic. It's that we are oriented toward the vision we have of the way we want the world to be. But our program implementers, and particularly the monitoring and evaluation staff in those funding entities, are focused very much on kind of incremental steps to get to longer term objectives and goals. And we miss each other along the way. And I think, in my experience, as I've talked to M&E people in the global funding structures, there's sometimes this kind of eye-rolling about faith-based organizations don't know what we're talking about when we ask them to develop a logic model or a theory of change or to articulate smart indicators for evaluating their programs. And so my hope for you as implementing programs on the ground is that by paying attention and learning more about M&E, we can lessen that divide and that gulf. We were carrying this out and we saw that there's no connection between conceptualization of stigma and the different kinds of outputs, the different kinds of products that were created by various kind of funding mechanisms, these kind of curricula, these kind of toolkits. There's no kind of interlearning or inter-impact across these kinds of initiatives. They're very siloed, and they're not connected to a broader kind of conceptual strategy or framework. This was done in 2018 as the Stigma Index 2.0 came out, and I heard about this a bit before the Amsterdam pre-conference, but heard more about it in Amsterdam and in the time after Amsterdam. And I was kind of astounded because here's this sense of a process by which there is a baseline mechanism of a survey that asks around a set of core indicators, communities in each country led by people living with HIV develop additional elements and processes related to qualitative research and qualitative studies, key informant interviews, focus group discussions, to dig down and to describe more complexly and more fully the various social cultural factors that drive stigma in their context. It sought input from local communities. It looked at contextual factors, all designed to implement a national strategy for addressing stigma in a country based on a framework that was implemented across all of the countries that participated in the Stigma Index process. The input process was well-grounded in qualitative research methodologies. It had an implementation process that was grounded in evaluation and implementation science and models. It developed logic models that included process, outcome, and impact metrics and measures and models. And I'm actually was wrong about this, and I don't know if in 2018 it was as clearly articulated. In 2018, I don't remember that there were specific efforts to assess religion's impacts, but as we heard earlier this afternoon, the Stigma Index 2.0 does actually ask specific questions in the topic domain of religion. So that part in the PowerPoint is incorrect. I was excited by that because the Stigma Index is methodologically complex. It addresses context and cultures in specific ways. But it's resource intensive and it's time consuming, and the project describes and contextualizes the drivers of stigma to inform action. It's not cookie cutter and one size fit all. But at the same time, it doesn't yield a set of core indicators across the globe that can be measured via a survey instrument. They're all country-specific and contextual. And in that way, those elements are not generalizable. And that, in my experience, is often at odds with the priorities of funders and policymakers and their expectations and demands in regard to monitoring and evaluation. And so as I looked at these two things, I wondered about what would it look like if we thought about the Stigma Index in the context of this effort to develop a monitoring and evaluation plan for this stigma curriculum we're carrying out in Nigeria. And as I thought about, as we look to see what those kinds of connections were across this very specific model for monitoring and evaluation and this larger global strategy, we also found that there were very few mechanisms, at least in 2018, for looking at the connections between what would be found in a process that the Stigma Index process would generate in terms of country descriptions and implementation plans, and these very site-specific initiatives and interventions in regard to stigma. And all of those red X's that you see there have got to become erased. We have to find ways for integration across these kinds of conceptualization in regard to what we mean by stigma and what we're doing in regard to stigma, not in siloed ways, but across the work that we're trying to do together. That's the ingredient, it seems to me, as someone who's not an evaluation scientist, for us to have some level of impact and to understand what that impact is. To develop integrated interventions across contexts that are site-specific, driven by and inform the efforts within local communities as well as national strategies, to learn from and adapt and replicate what's worked in one place based on the findings from the assessment in another place so that it can be adapted and modified. It's not cookie-cutter replication, but context-informed integration. It's necessary for fine-tuning and adaptation based on impact on the input of other programs' findings. How does what one program's doing in regard to stigma possibly impact what we can do, and how can we fine-tune what we do based on that? And it seems to me we really need to always be thinking about what we really mean when we use the word stigma. What are we conceptualizing and talking about when we talk about anti-stigma efforts? Because we don't often actually ever say what stigma is or define it. Most of the curricula that I look at and most of the models that I look at may have some minimal reference to the existing literature on the concept of stigma, but there's actually very little kind of interrogation about what stigma is and what actually works to address it. Because UNAIDS has developed a 5-year strategy for end inequalities, end HIV/AIDS, this kind of effort is really, really important, it seems to me, and the work within our Faith Initiative. And so I would say that this kind of integration is an important component of the strategic plan and what the Faith Initiative will do in regard to supporting that plan. But is it feasible and is it sustainable? I think that's an open question in regard to developing a plan of this scope and scale and magnitude. And if it's not in regard to these kind of elements, will funders require us to continue to carry out M&E frameworks that are pigeonholed into the work that we do that's very specific to faith context, that are not just merely unhelpful, that really don't capture and help us to see what it is we do that contributes, maybe distinctly and uniquely contributes to anti-stigma efforts, but that those frameworks, because they fail to capture those kind of distinct contributions of our faith partners, may actually be counterproductive. We're spinning our wheels and our efforts and our energy carrying out those monitoring and evaluation frameworks that actually don't capture the scale and scope of what we do as faith partners, and kind of sets us up for, well, you're not really doing anything, when in fact I think we're doing a lot. And then finally, where would faith fit into this kind of rubric? Can we work to create with our implementing partners outside of the faith context and with our funders an assumption that religion is a social structural driver of both stigma and anti-stigmatizing attitudes efforts, and provides one of the kind of social structural forces that we can use, that we have to think about in addressing stigma. And religion is not only, this is an important component, but it's not only about the amount of HIV services that faith-based health providers provide in Kenya. That's really, really important, but it's not the only impact of religion in regard to stigma especially. And we also, in this room, have to be driven by an assumption that religion does not always contribute to positive outcomes. Now, I know that we all know that, but in regard, or I hope we do, but that in regard to being upfront and transparent about the work we do and trying to make the case for the importance of faith-based partnerships, I wonder and worry if sometimes we approach that kind of work from an all or nothing kind of framework of your faith partners are the magic partners who will usher in a golden era of perfection and all stigma dissipates away magically because you brought pastors and imams to the table. In fact, there are times and ways in which religion actually drives stigma, and I don't think we do anyone any favor by not acknowledging that and by working to honestly and respectfully engage in what will have to be sometimes difficult conversations with our colleagues in our religious tradition to speak and talk with them about the impact of how religion itself helps to drive and maintain stigmatizing attitudes and efforts. And if we can actually get to the place of doing that, in the long term, it will help us to be more able to articulate the power of religion and also to articulate strategies for understanding how we dismantle some of the power of religion that doesn't contribute to a world of health and wholeness, and to amplify and maximize those elements of religion that do. Thank you.
John, I thought you mentioned at the beginning that you are not an M&E expert.
No, but I did go to seminary, so I worked to be yes.
Thank you very much. This is impressive. So, time is not on our side. Thank you, Shoba, Tiffany, and John. But I think we'll just allow one question. Only one question, so yes, we'll give them.
I want to thank everyone who's spoken this afternoon. It's really been a fascinating experience. I think I'm going to address something with John, though, on my part. First of all, I think that you have to include faith-based organizations in planning these things. And John, you talked about meeting with the federal people, with the team on the ground, I assume, of the federal people on the ground. But I think maybe we have to have more dialogue together in terms of the faith-based people and especially the key populations, which we heard about in some very good practices today. And I think that's where we have to start. Also, it was fascinating this morning when ECHO didn't talk about anti-stigma, but about welcoming services. And I think you'll have a lot more openness on both parts to have that positive dialogue if we talk in that way, instead of an anti-stigma. And I'm not denying that stigma, exists and exists within faith-based organizations, and especially, as came out today, within the general culture in many, many places. But I just think we have to maybe change the way we approach this, and then we could still have, the whole logic framework, but from a much more positive way, and also making sure that we're checking back with each other, both the key populations and the faith-based organizations. And maybe the national and the international agencies need to listen a little bit to what's actually happening on the ground.
Yes.
Father Bob, I agree with you completely in what you just said. In regard to the case study I gave, the implementing partners that were at the table along with the country officers and representatives of the priority country government, the Ministry of Health in country, were from our faith-based implementing partners. There were 2 of them who were represented in the Faith Initiative. So, and part of what was really interesting in terms of that effort was the kind of disconnect as to how the different groups were trying to articulate what they wanted the Stigma curriculum to achieve and the vision they had in terms of measuring how we would see if it actually did that. I really want to emphasize what you just said about kind of can we articulate and find a way to describe how our efforts encourage welcoming and hospitality and don't dismantle anti-stigma. I mean, because I think funders and implementers are always going to look for smart, measurable indicators around anti-stigma efforts, and they're going to quantify that in some way, or they're going to work to develop that in a kind of instrumentalist description of what will actually get us there. What's distinctive, I think, about faith communities, or what's powerful about faith communities, is that we often articulate those kinds of attitudes in exactly the way you described. We don't articulate it as having an approach in clinical setting where men who have sex with men receive these kinds of interventions. We articulate it as our door is open to all people, and we articulate it as welcome and hospitality. The intersection between those two ways of understanding these kinds of issues, I think, is where we do something really distinctive in the work, and we have to find ways to describe that. I think the most important way we actually find to describe that is not just by doing surveys around these kind of quantitative indicators, but also to describe in narrative, in story, because religious traditions operate within the realm of stories, that we tell the stories of what hospitality and welcome has meant in those kinds of contexts. And I think we have to multiply the both and of that, and too often we've worked in the either or of it.